My name is Uche Ndefo, and I am a professor at Texas Southern University, and I am one of the associate directors for the Center for Biomedical Minority Health Research, the Community Engagement Core. Today, our focus is going to be on prostate cancer. So the title of Dr. Hunter's presentation, Together We Can, Awareness, Screening, and Prevention for Prostate Cancer.
Texas Southern University's Center for Biomedical and Minority Health Research Community Engagement Core is funded by the National Institute of Minority Health and Health Disparities Research Center for Minority Institutions program. The CEC works directly with communities to identify and address health-related concerns and reduce health disparities related to ethnic minorities. We provide health education and partnerships with healthcare systems, federally qualified health centers, community and faith-based organizations. For more information, visit us on social media at CEC Texas Southern U, or give us a call at 713-313-1233, or send us an email at cbmhrcommunity@tsu.edu.
All right, so welcome everyone. Thank you again for joining. Please remember to be muted throughout the presentation. There will be a question and answer session at the end, but we also want you to post your questions in the chat box during the presentation. And when Dr. Hunter is done with his presentation, I will ask him the questions that show up in the chat box. At the end of his presentation, we're going to play virtual bingo using some of the information that we've learned today from his presentation. So please stay on to play with us and for a chance to win a prize. I want to thank our partnering agencies. Today, we have the Houston Texans YMCA partnering with us for today's seminar. The other partner we have is Legacy Community Health, which is a full service federally qualified health center here in Houston that identifies the unmet needs and gaps in health related services and develops client-centered programs to address those needs. They're partnering with us today, as well as Canopy, Elevating Life Above Cancer. It's a cancer survivorship center. They are Silicon Valley-based nonprofit that works with leading healthcare systems to ensure that patients never get lost in the system that are going through cancer treatment. Okay, let's hope this works. There we go. And this is a video that should introduce our other partner at the DAWN Center, the Diabetes Awareness and Wellness Network, which is a department of the Houston Health Department. Well, we'll maybe try that again at the end and maybe it will work then. Okay. At let's see, at the end of the seminar, there will be a survey. We're not going to do that yet. And I will actually turn this over to Dr. Hunter. So I'm going to stop sharing my screen and I will. Yep. Hold on one second. Sorry, guys. Dr. Hunter, give me a second. What happened to my Zoom? Okay. So obviously this is live, and whenever we do that, things happen. That shouldn't happen. Okay, let's see where we are. Can y'all see my screen?
Yes, I can see it.
Perfect, and it's showing the right stuff. Okay, So there will be a survey at the end and we'll provide you with the link at that time. We are going to have a prostate cancer work group. So if you're interested, if you're a Black man 45 years or older, and you're interested in helping us with this work group, it's going to be 60 to 90-minute sessions once a month, where we'll just get some opinions of Black men on the topic of prostate cancer. And then on Tuesday, October 19th, we're going to have breast cancer as our topic, and it's still going to be awareness and screening, but it's going to be for breast cancer for October. I have the pleasure this morning of introducing you to Dr. Rodney Hunter. Dr. Hunter is a clinical associate professor here at TSU in the College of Pharmacy and Health Sciences. And he is a clinical pharmacy specialist at the Breast Medical Oncology at University of Texas Health Memorial Hermann Cancer Center. He has served as the program director for the TSU Breast Cancer Screening and Prevention Center that was funded by Susan G. Komen. He actively works with us here at the Center for Biomedical and Minority Health Research on research projects and especially on our community initiatives, our community outreach initiatives. He also serves as a clinical assistant professor in the Division of Internal Medicine at the Department of Oncology at UT Health at the medical school. He is a proud graduate of Texas Southern University from the College of Pharmacy and Science and Health Sciences, and he completed his oncology fellowship at MD Anderson here in Houston as well. So with all those credentials, this is the guy we have for y'all today, and he will be speaking to you on prostate cancer. So Dr. Hunter, I'm going to go ahead and turn it over to you.
Excellent. Thank you very much, Dr. Defo. Let me get my screen set up to give you guys this presentation we got going on today. Okay, how do we look there?
Perfect.
Well, I hope. Well, first of all, thank you, Dr. Defo, for introducing me as a colleague and a friend. It's a pleasure to be able to work with the CEC and definitely distribute this information as we talk about prostate cancer. And appears next month, we'll be talking about some other things as well, with breast cancer being something I also have a lot of interest in. As we talk about the objectives, I will talk a bit about the functionality and the anatomy of the prostate gland. I think that is something that we as men, of course, we don't talk about it as much, even when we're in school. It's not something we're excited to talk about in anatomy and physiology, our prostate gland. We'll also talk about some of the pathology, as well as the etiology and prevalence of prostate cancer, some of the various types of treatments that patients can receive if they do actually get prostate cancer, some lifestyle modifications that you may be able to make to help or lower the risk of developing prostate cancer. And then finally, just some resources that you can find more information on prostate cancer. Of course, you know, our program here at Texas Southern with CEC will have plenty of information and things going on with prostate cancer. But if you want to, you know, do some reading on your own, I'll have some of those references of places you can go to gather that information. So we talk about the prostate gland itself. It actually is like a small walnut-sized gland that's below the bladder in men, and it surrounds the urethra. One thing about the prostate gland is it actually stores and makes the components of semen. So of course, it's very instrumental in reproduction, and actually it can slow or stop the flow of urine. So at the end of the presentation, you'll notice I'll talk a bit about something called BPH. Which is a hyperplasia or overgrowth or enlargement of the prostate, which is commonly goes parallel and hand in hand with prostate cancer, to where some patients maybe think they have prostate cancer, but they actually just have very severe BPH. But the effects on your flow in the urine are very similar to prostate cancer with that type of ailment. So looking at an overview, prostate cancer affects like over 200,000 men in the United States alone every year. So it's extremely common type of cancer. It's the most common type of non-skin cancer in men in general. That's not just in the United States. That's actually in the world. And as far as those malignant cells in the prostate gland developing, one thing about it, and it's a good thing, if you will, because with prostate gland cancer, it has less of a chance to metastasize and spread to other areas of the body compared to other cancers because of the anatomy of it being that small gland that kind of encapsulates any abnormal growth. It keeps it under control until it gets very severe. So what you have is a very slow progressing tumor or slow progressing disease compared to like other types of cancers. Majority of patients are asymptomatic for 5 to 10 years when they have prostate cancer. So it's something that you could very well have prostate cancer, have no symptoms for years and years before it really starts to cause you problems and you really have to seek medical attention. Uh, Patients who are symptomatic, though, that usually means that the prostate cancer is spread to the areas that we don't want it to spread to. So those are like your stage 4 patients, which are metastatic. So we certainly don't want patients to wait until they have symptoms to seek medical attention for prostate cancer. Once it's identified, we want to address it at that point, and you always have better outcomes long term. And you also are going to look at a patient who addresses it. The faster you address it, the less types of treatments you'll need to receive on the back end. So some symptoms, and I'll spend some time on this just because these are really the major places where you're going to possibly see it's going to prompt you to go into your urologist or your general practitioner initially, and then maybe refer to a urologist to identify if you are a patient that has prostate cancer. So the frequent urination, especially at night, is something that's consistent with BPH as well as prostate cancer. So that's why, like I said, it's always on a differential where when we're diagnosing patients with prostate cancer, we do want to rule out them having that BPH. The hesitancy or the interruption in the urine is also something. So you notice what I said, that prostate gland is right by your urethra and your ureter. So it's going to possibly affect like how you urinate as the prostate enlarges. Trouble controlling your urine is also something that and discomfort while urination is something you possibly see. In more severe cases, you can even see blood in the urine or in the semen if you have prostate cancer. Difficulties with erections and painful ejaculation is something else that occurs. You'll see as we talk more and more about this that prostate cancer can definitely be hand in hand with erectile dysfunction and problems with sexual activity for men. So it's something that affects a host of different places. The last symptom there with frequency of pain and stiffness in the back, in the thighs and the legs, the pelvis. That's actually a common place where you possibly see metastasis of the prostate cancer to those large bones that are in that area. So when we see this, of course, we have a certain level of, we're alarmed because we're hoping that there's not a very severe case where the prostate cancer is metastasized to stage 4. So looking at risk factors, and this is going to be something that you'll see specifically with this being a minority initiative, the programs that are essentially controlling or putting on this presentation that we're having today. The minority patients, specifically African American men, actually have a specific screening that's earlier than the normal population, and that is because there's postulation about the reason why patients who are African American have prostate cancer at an earlier age and sometimes have it more frequently is because of the production of testosterone. Prostate cancer is a completely hormone-driven disease to where testosterone feeds the tumor that's in the prostate gland. So as you have more and more testosterone flowing, the gland or the cancer continues to enlarge and get larger and more aggressive. So the more testosterone is circulating, the more severe or quickly the tumor is growing. And there's been studies that have also shown that African American men have more circulating testosterone average. And that is the leading reason or leading cause associated with us thinking that the reason why patients have increased risk of developing prostate cancer if they're African American. As you can see, it's not a disease that typically affects younger men, but you do have, 1 in 10,000 cases that are diagnosed of patients that are below the age of 40. Numbers jump up when you go between ages 40 and 59, with it being about 1 in 38. Then the vast majority of your prostate cancer cases are going to be around age 65. So you have, the 60 to 69 age being 1 in 14 of those cases being diagnosed. Furthermore, when you talk about the age of a patient being diagnosed, as I talked about earlier, your prostate cancer, you can live and operate with prostate cancer for years and years before you actually really seek medical attention and it gets severe enough or serious enough to where it's altering the way that you urinate or really affecting you from a sexual perspective, or you're having pain in your lower extremities or your back or things of that sort. So that's just something to understand and something to know that, with prostate cancer, you are going to expect patients to have it at an older age, but understand that your screening should start in the beginning so that we can catch it as early as possible. And I'll talk a little bit more about diet, but just to go ahead and establish it now, the intake of fatty dairy products and red meat have also been associated with as a risk factor for developing prostate cancer. So family history is actually, it even trumps a patient being African American. So first degree relatives that are having prostate cancer at an earlier age, that's at the top of the list as far as like what are we worried about in reference to patients being diagnosed. If you have a first degree relative, a father, brother, or son that has history of prostate cancer, you actually have a 2 times increased risk in developing prostate cancer. As you get more and more individuals that in that lineage where they are first degree relatives, you increase the risk even more by up to 4 times if you're talking about more than one first degree relative having prostate cancer. Patients who have family history of prostate cancer have a higher incidence of developing it at an early age as well. So let's say, we're saying our average age is 50. So we're saying that, we're going to start most patients, we're going to start screening them at 50. Well, of course, African-American men, we've already talked about that being 45, but patients who have first degree relatives, fathers, brothers, or sons, the recommendation is actually 40 years of age for them to be actually identify if they're going to actually be screened for prostate cancer. So the risk is actually highest for men who are diagnosed before age 65. So that's the key, that that's the younger age I was speaking of, age 65. So you see it at age 65 or above, you're definitely going to be worried about that patient possibly needing to get their screening much earlier. There are some hereditary cancer syndromes that are associated with developing prostate cancer, with Lynch syndrome being at the top of the list, and also BRCA1 and BRCA2 mutation. So regardless if you're a lay person or you're a healthcare professional, you probably have been in contact with somebody talking about BRCA1 or BRCA2 mutation, but it was probably typically women. So you think about this and you're like, oh, women have this BRCA1 and BRCA2 mutation, and they're the ones that are gonna, we need to worry about it in. Well, not actually the case. But women, and of course, that's a conversation next month, ovarian cancer, breast cancer, those are things that can possibly, that the risk is increased if a patient has a BRCA1 or BRCA2 mutation. But actually, BRCA1 and BRCA2 mutation have been associated with increased risk of developing prostate cancer as well. So it's something to think about. So when we're doing genetic testing, and we'll talk a little bit about genetic testing towards the end of the presentation, when we're doing genetic testing, we definitely can look at the BRCA1 and BRCA2 mutations being something that can possibly increase the risk of developing prostate cancer. So nationalities and ethnicities in reference to prostate cancer, to put some numbers associated with the actual recommendation. With African-American men, they're 61% more likely to develop prostate cancer when you compare them to the Caucasian counterparts. And that nearly ends up being 2.5 times more likely to die of the disease as well. Because while it is typically caught at an earlier stage and it hasn't spread to other areas of the body, unfortunately with men, which is the passion and the reason why I'm here to talk to you as an African-American man myself, we tend to be the worst when it comes to seeking medical attention for things that are not really, really causing us an issue. And unfortunately with prostate cancer, by the time it's a serious issue for you, it's probably stage 4, which means that's the worst type of prostate cancer to have because it's not curable. So when it's just, causing small changes in our daily lifestyle, like maybe when we urinate, we notice there's a little bit of pain, but it's not so much that we even need to go in and, get any medications for it. We can continue to let that linger on until the point where we are having severe lower back pain, because now the disease is not only in our prostate, but it's spread from our prostate to our lower back. So now we're in a much more serious medical situation when we actually are diagnosed. And those are reasons behind the 2.5 times more likely to actually die of the disease compared to like our Caucasian counterparts. Also, with prostate cancer, when you look at other minorities, actually, Asian Americans, Hispanics, and American Indians, less often is it diagnosed in that patient population. And it's much more prevalent in North America and Northwestern Europe compared to other parts of the world. And some of that is associated or is postulated is related to diet, the types of meats we eat, the processed foods, the dairy products, all of those things associated with the incidence is where it really comes from. So the screening mechanisms for prostate cancer. So when you talk about the screening mechanisms, there's a PSA, or a prostate-specific antigen blood test that can be performed for patients who are being screened for prostate cancer, as well as a digital rectal exam. The digital rectal exam is actually to palpate or to touch the actual prostate to detect any firmness or any enlargement. And that's going to be one of the clinical ways to actually identify if a patient should actually get a biopsy to diagnose prostate cancer. The prostate-specific antigen is elevated in patients who have prostate cancer typically. However, it's also elevated in patients who have BPH, and it's also elevated in patients who have recently had trauma to their groin area, or have had a digital rectal exam. Actually can possibly elevate the prostate-specific antigen as well. So any trauma or any interruption in the urethral flow, all of those things can possibly increase the prostate-specific antigen. So while it is a test that we can use to help to alarm us if it's elevated in patients who were suspecting they may have prostate cancer or they're at the screening age, it's not the end all be all of how we diagnose prostate cancer, but it will give us some information that we may be able to use to continue to investigate if a patient has some abnormalities, either in their digital rectal exam or their prostate-specific antigen blood test being elevated. The American Cancer Society actually recommends that both tests be offered annually to patients beginning at age 50. So this is your normal population. These patients would essentially have a recommendation to have it at age 50, get a DRE and a PSA test on an annual basis. Now, when you go into your high risk categories, that's where African American men lie, and that's to start testing at age 45. So age 45 being the standard place there. Also, strong family history, and that would be like that maybe one first degree relative having prostate cancer before the age of 65. Now, when you go into the highest risk category, the higher risk category, that's when we're talking about multiple first degree relatives being affected with prostate cancer prior to the age of 65. So that screening then ends up being the age 40. And if you remember, like patients who have those multiple first degree relatives that have developed prostate cancer at a point in time, they end up being at an increased risk of developing prostate cancer because of that at an earlier age on top of everything. So it's something to definitely keep in mind. Now, when we are diagnosing prostate cancer, let's say that elevated PSA test has led us to this place where we feel that the patient, they have very suspicious for having prostate cancer. Well, until this actual biopsy is performed, then there cannot be an actual official diagnosis. So we can't diagnose a patient with prostate cancer just from having a high PSA or having a palpable or a firm palpable prostate from a digital rectal exam. We need tissue samples that are going to confirm that we're looking at prostate cancer before we proceed with any types of treatments or any recommendations from a prostate cancer perspective. Everything is done on a local anesthesia, and they do actually take a hollow needle and pretty much extract cells from the prostate to identify them under a microscope to then see from a pathologist perspective if these really are cancer cells. So frequently, and this is just patients in general, there's always the conversation about how often can a patient be cured from whatever disease state we're talking about, if you will. So with the majority of prostate cancer cases, they are being diagnosed at a much earlier stage. And once they receive the typical treatments, which we'll talk about the type of surgical management that patients can receive, we'll talk about some of the the injections, the tablets they might take, the chemotherapy they may need. We'll talk about all of those just briefly towards the end of the presentation. But once those patients are at a place where they've received those, they're very, very it's very likely that they're going to be disease free for the remainder of their life. 90% of the cases that you see in reference to prostate cancer are the local or regional stage, which means that they have not spread outside of the area of origin of the prostate. And those have very high cure rates with, some studies will say 95 to 97, 98%. So you have 90%, over 90% of the cases having a cure rate that's in the, approaching 100% disease-free survival after 5 years of being diagnosed. So the bottom line or the takeaway point from this particular slide is that if you can catch it early, you're at a very, very good place. And that's why the screening and all of the time I was spent early in the presentation talking to you about when you should be screened and how often you should be screened, and identifying if you have those relatives that may have been diagnosed with prostate cancer at a point in time. As long as you can stay on top of things and catch things early, which majority of patients do, but some don't, that 10% are those patients that end up succumbing to prostate cancer and lose their life is because they were diagnosed at that later stage. You have a much lower chance of curing the disease if you're at a very advanced stage when you're diagnosed. So treatment. Treatment typically starts, this is like one of the number one things, unless you catch it really, really early, is really either a partial removal of the prostate, where you're essentially removing the portion of the prostate that has the cancer growth on it, or you can actually do a radical prostatectomy where you're removing the entire prostate gland. And then there are situations you can do an open prostatectomy. The open prostatectomy could remove just portions of the prostate, but it's like in the middle to where you could have a two-thirds of the prostate removed, or you could remove the whole prostate. But the procedure essentially is trying to identify where the cancer is prior to that saying we're going to take all of it, because the identification of where the prostate actually has cancer, if it can't be visualized, then you are in a situation where you're shooting in the dark, if you will. So the open prostatectomy tends to be what most surgeons will opt for, to make sure that they're not removing more tissue than they have to remove. Of course, if they can leave, the more the prostate that can be remaining after the surgery, the better the long-term symptoms for the patient in reference to their sexual activity, urination. All of those things are better if there is some of the prostate at least functionally being left over after the surgery. So radiation ends up being a mainstay in the treatment of prostate cancer. So patients who develop prostate cancer, they will typically have some level of radiation. Depending on what type of surgery they get, actually dictates like exactly what type of radiation they're going to receive. But the external beam radiation is the most common to the area, and that also unfortunately affects the functionality of the nerve endings, which once again can possibly affect sexual activity. The hormone therapy is a combination of two things. So in the hormone therapy, and as we said earlier, testosterone is the leading reason why the prostate continues to grow abnormally and continue to enlarge to the point where the cells are growing outside of the prostate and outside of the anatomical region for the patient. So the hormone therapy is focused on blocking the activity of testosterone in the patient's body in general. So that does obviously stop that fuel that the prostate cancer needs to grow, but it affects you as a man as well. So you're at it's like a seesaw effect, where we want to protect you as a patient, but we also want to make sure that we're starving the prostate cancer of what it needs to continue to grow and thrive, which is testosterone. Chemotherapy is actually something where if I'm talking to patients about chemotherapy in reference to prostate cancer, a lot of times they're more in the advanced stage of the disease. So while we are going to use platinums as well as taxanes, these are just types of chemotherapies, we would love to stay in that realm where we're just using the injections for the hormones and tablets to block the hormones, and doing surgery and doing radiation. But if we do need to take it to that place, then at the later stages and in the more severe cases where patients have stage 4, stage 3 prostate cancer, then you would use chemotherapy in that patient population. So some potential side effects long term when you're talking about undergoing that prostate surgery, incontinence or the controlling of your bladder if you do actually have that prostate surgery is something that can possibly happen. Impotence because of those because of the nerve endings possibly being affected from the surgery. And you do have nerve sparing surgery that's always attempted to avoid the impotence, but if it cannot be avoided, then it's something that can certainly be a long-term side effect. Of course, the prostate is the major producer, if you will, of semen. So a patient has a prostatectomy and the prostate is not functional anymore, then they are not able to make semen anymore. So that's another effect long term of a patient having prostate surgery. So two things that are non-cancerous that affect the prostate in a very similar way to what you would see initially when patients are being diagnosed with prostate cancer, and some of those symptoms are BPH, which of course enlarges the prostate, enlarges not at the point where it will infiltrate any other area of the body and become cancerous, but definitely from anatomy standpoint can affect sexual function as well as urination. So with BPH, we have patients that complain about the same type of symptoms that you have with prostate cancer because of that enlargement and the pressing on the urethra or blocking of the urethra once the prostate enlarges. Prostatitis is essentially just the inflammation of the gland. And with prostatitis, it can sometimes just happen. It can happen at any age. And some patients have it from an acute perspective, but usually if patients are having it on a chronic basis, then medication is definitely what we would use to try to get to the bottom of it. But it's usually an infectious reason. So that means that we need to give patients antibiotics and then things that will help the symptoms and relieve the symptoms. So prevention of prostate cancer. So lifestyle modification certainly can prevent prostate cancer. I would tell you at the top of this list on what I have on this slide would be smoking. Smoking is the biggest cause and effect, if you will. So smoking is certainly related to the development of prostate cancer. The diet, quickly follows behind with that meat and cholesterol. As you eat that more red meat and have elevations in intake and cholesterol, that increases your risk of developing prostate cancer. So there's recommendations about eating low-fat diets, fresh fruits, vegetables. This helps you with things not only outside of prostate cancer. I'm sure that there have been other presentations that have been done in reference to the CEC about just changing your diet to help with controlling your cholesterol and controlling your blood pressure, controlling diabetes. This goes hand in hand with cancer. Coincidentally, a lot of the recommendations from a diet perspective for cancer also help with these other metabolic syndromes that you would see, like blood pressure issues or like patients who have high cholesterol or have diabetes. And also exercise, relieving stress, getting great rest, reducing your stress level. All of those things actually are beneficial. They have links to them decreasing the risk of you developing prostate cancer and cancer in general. So genetic counseling, I think with genetic counseling, it's certainly worth having the conversations. There's two different types of patients that we will essentially making sure that genetic counselors understand if you're in group 1 or group 2. Certainly group 1 is those patients that are cancer free, but other medical conditions may cause them to have an increased risk of developing cancer. But group 2 is the type of patients, and maybe you could be in group 2 or group 1, both of which can benefit from the genetic counseling occurring. But with this group, looking at the genetics and the fact that you have a cancer diagnosis and you're wanting to possibly protect yourself from other types of disease states that you might develop, or you might want to actually get your family members that are at high risk involved so that you can possibly catch whatever types of genetic abnormalities you may have or they may have, and have a more aggressive screening mechanism for those types of patients. We frequently see these patients in the cancer center I practice at currently and my previous practice sites as well. So we're always wanting to make sure patients have all the information that they need and want in reference to cancer and their genetics. Everybody's genetics is different, but we definitely have identified multiple genes that can increase your risk of developing certain types of cancers. And if we know you have an increased risk, you may qualify for a more aggressive screening schedule, and that could possibly save your life, or at least cause you to catch the cancer that you may develop earlier, to where we have better treatment outcomes long term. Sources and places where you can possibly obtain information: Houston Methodist Cancer Center, MD Anderson Cancer Center, Memorial Hermann Cancer Center, which is the cancer center that I currently practice at. The Prostate Cancer Foundation itself, a very great resource to help patients who are undergoing treatment, patients who are about to start treatment, patients who are possibly needing help from a socioeconomic standpoint. A Prostate Cancer Foundation is very good at raising money, as well as helping patients who are going on that journey, who have prostate cancer. And lastly, Texas Oncology is a great place to obtain information about prostate cancer, and possibly, assistance when it comes to obtaining treatment for prostate cancer. And I know there may be questions in the chat, or you guys might have burning questions that you want to talk to me about. I'm very open to answering those questions to the best of my ability. And if I can't answer those questions, I can certainly, you can gather my information from the CEC, and we can make sure we get you the information that you need. But thank you for your attention today. I hope some of the information I gave you was helpful, and I hope you enjoyed the presentation.
Thank you so much, Dr. Hunter. I definitely learned things that I have maybe forgotten since pharmacy school, and were great reminders for me. I think the most impactful thing I heard today was, having different screening recommendations for different people, right? Because, you just kind of, at least with us, we just learn that, everybody should get screened once a year. But hearing that the screening recommendations can be different depending on who you are, or what you look like, and what your history is very impactful. Because I know with what was it, colon cancer, right? With Black Panther.
That's correct. He was young. He was actually younger than you would have typically wanted to screen someone. So a patient of his age wouldn't necessarily be a patient you'd be like, they need to go in and be screened.
Yeah.
So, and of course, like, it got so severe with him, of course, it took his life. So it's always something I talk to patients about very commonly in the community, whether I'm in a community setting like this, or my patients in the cancer center, about their family members who, of course, are at increased risk of developing cancer because they're the son or the daughter or the father of whoever has been diagnosed. Making sure they understand that screening saves more lives than any chemotherapy that I can, write or do or get for any patient, or any tablet or any injection. Screening and finding the cancer early on, that saves more lives than anything.
Absolutely. Absolutely. That was very eye-opening for me. While we wait to see if anybody has any questions, should we go ahead and play our bingo? All right.
It says some people are raising their hands.
Oh, okay. I see it now. The Houston Texans YMCA has raised their hand. So let's see if I can allow them to talk. Okay, you should be able to talk now. Are you able to speak? All right, well, I see another hand raised. Mr. Crossland, Bill Crossland?
Yes, ma'am. Can you hear me?
Yes, sir. Good afternoon.
Good afternoon, and thank you so much for this opportunity. I am a 6th year prostate cancer survivor. And my question to, I thank the doctor for this information, is I have difficulty not finding, but in talking with brothers about the issue of getting yourself checked out now. These are younger brothers, older brothers, just brothers, period. So I wondered if he had some that's not on the page that he could share. Brothers just don't want to, they don't want to deal with that area of their body.
It's very true. Thank you for the question, and thank you for bringing up a big point that I was alluding to, but I didn't want to just make the whole presentation about that. But I did spend some time talking about the fact that I think African-American men are notorious for not seeking the amount of medical attention that they really deserve. And of course, a part of it could be us just wanting to maybe be tough or power through whatever it is that's ailing us to continue on with life. But I think that when it comes to your health and what I've seen that has very good results, and it's the same way actually with African-American women and breast cancer, I think, is sometimes, hearing or talking to individuals that look very similar to you about your health and them urging you sometimes can help. So you being a survivor, you yourself could be an advocate to really help. And it sounds like you're already kind of doing that. But since I've been in the realm of oncology, I frequently come in contact with patients that gravitate to me because we look similar to one another, and they take my advice. They listen to me more maybe than listen to anybody else on the team because we look similar to one another, and maybe there's a increased level of trust. But I exploit that to the fullest of my abilities to try to help as many patients as I can, save as many lives as I can in my role. And I'm, happy and thankful to be able to do that. But I continue to do it knowing that sometimes they're listening to me because I'm a young brother, maybe like they are. And I use that to my advantage.
Thank you so much. That was a very important question and a very important point. Let's see. Mr. Crossland, did he answer your question?
Yes. I really hate to say this, but I'm gonna say it out loud. One of the persons is my own son, and he has 3 sons. So you can see my severity in terms of wanting to get that information, get him to, and it might take, I'm currently under a Caucasians, so I may follow with Dr. And ask him if he'll go see a brother doctor. So that's I really appreciate it. That's
no problem.
Yes, we have found that the comfort level with the provider does help. All right, our friends at the Houston Texans YMCA, I have unmuted you, so you can go ahead and ask your question.
Yes, the question is, prostate cancer, is it hereditary?
Yeah, the short answer is yes. Unfortunately, it's definitely a strong hereditary component. So an individual like Mr. Crossland, who has a son, and his son has sons, all of those individuals are immediately at a higher risk of developing prostate cancer. So him being an advocate and trying to talk to his family would be something that would be important for their safety long term, honestly. So there's the screening recommendations, or it's earlier if a patient has a first degree relative, and that's really because prostate cancer has such a strong hereditary link.
Okay, we have another question. Thank you.
I know you say it's hereditary, but I'm 67.
Mm-hmm.
And so my grandfather would never have talked about anything like this, nor my father. So my brother and siblings would never know if that was hereditary. They would have gone to that grave keeping that as a secret.
Yes, unfortunately, a lot of the cases, like the cause of death or the reason why a patient, we find out actually, and they've received no treatment. So essentially die of prostate cancer and have not received any treatment at that point. That 10% of patients I was talking about that are diagnosed, and it's not a local disease, it's not a regional disease, it's metastatic when they're diagnosed. A lot of those patients, we maybe find out they have prostate cancer after they've already died, unfortunately. So I think your question leads to what do you do if you just don't have the appropriate information from a family perspective to know if somebody has had prostate cancer in your family. Of course, if you're African American, you already know that 45 is the age you should start the digital rectal exams as well as the prostate specific antigen testing. But even on top of that, you can certainly get genetic screening if you have curiosity. That puts you just being an African-American man puts you kind of in group 1, even if you don't know if somebody has a history of prostate cancer in your family. And those genes can sometimes show an increased risk of certain types of cancers, and prostate cancer being one of them, if you have mutations in certain genes. So genetic counseling and making sure, of course, that you start your screening age at 45, which is a relatively young age when you really think about it. I'm 39 now, so I mean, I'll need to start getting screened for prostate cancer, just a few years. So it's something that is going to affect. It is going to affect young men, and we tend to be the worst patients, but it's something that needs to be done. So you're not in that percentage of people who could have been saved but weren't saved just because they didn't get screened appropriately.
Thank you.
You're welcome. You're welcome.
We have another question.
Okay, perfect. Go ahead, Ms. Bean.
Okay, my brother is age 65 now, and his doctor asked him to come in for a screening, and it took him the longest before going in to have that screening. I don't even know the outcome of it, but why is it that men are hesitant about going in for a screening when it affects their health?
I can smile just because I know I'm not the best patient. I mean, of course, my wife probably is the one that's probably dictated me going in and getting certain things done to me that I wouldn't have had done if it hadn't been her really on me about it. And sometimes that's where we need the assistance of our community, whether they be a woman in the community or another man who understands the importance to get us to the place that we need to go in reference to getting checked out. Because a patient is age 65, like you're saying, theoretically they would have been being checked at least since they were 50, but at minimum for multiple tests that would have been done at 65. So it's just really staying on top of people and understanding that there has to be a focus on them, on their health and themselves, taking care of themselves, because ultimately getting that exam is gonna help you more than anybody else. And I can go further with the prostate cancer screening specifically. The digital rectal exam, the way that the exam is done, of course, is not something that men are just excited about having done to them either. So that's another component of it. But, when it comes to either getting that exam or developing stage 4 prostate cancer and possibly dying prematurely, I think that's the conversation I try to have with individuals. Yeah, do you want to get it? No, but do you want to be somebody who could have been diagnosed at an early stage and been cured of prostate cancer and live a full normal life? Or do you want to battle with all the things you have to battle with once prostate cancer gets extremely severe and serious?
Thank you.
Thank you.
We have another question.
Yes, please go ahead.
Thank you, ma'am.
The question is, they said you go to the bathroom more at night. How about if you go more during the daytime than at night?
Actually, the urinary frequency in general is a symptom of either BPH or prostate cancer. So going to the restroom very frequently could be a symptom of of prostate cancer, but honestly, patients, the majority of patients that are going to the restroom very frequently, the first thing I would check actually for is diabetes, not prostate cancer. Although prostate cancer is extremely common, you know, I'm talking about 250,000 patients a year. Diabetes, you're talking about tens of millions of patients a year. So I would probably first go see if that patient has any problems with their sugars, which of course, like you can sometimes have more urination if your sugars are out of control, or you know, of course, like having infections can sometimes affect like how often you urinate. There's a host of different reasons, but yeah, the frequency in general can be a sign or a symptom of prostate cancer, not just at night. At night most commonly, but it could be during the day as well.
Okay, will it hit you all at one time that you have to go to the bathroom?
No, very, very slow actually. Very slow, because you have to realize that what's happening and the reason why you're having these issues anyway is because the prostate is slowly getting larger and larger. And as it presses on the urethra, that's the flow of the urine out of a man's penis. So as it starts to do that, it could be a period of time where they have a normal flow, but then positioning changes, or there's a slight increase in the size of the prostate, and all of a sudden the flow slows down substantially, and then they have trouble urinating. But then the position changes again, or the growth of it changes again, and then you're back right to square one, to where a patient is urinating very frequently because of the anatomy of the prostate compared to the urethra.
All right,
Thank you.
We have a couple of more questions.
Mm-hmm. Sure.
What is the life expectancy for a person that goes undetected for any length of time?
Well, you're asking like how long does it typically take if a patient like has prostate cancer and doesn't do anything about it?
Yes.
Okay, so typically what happens is, and this is where the screening recommendations come from. So the average age of 50, telling the patient they need to be screened by 50, with the average age being 65, that is being diagnosed, is essentially showing that growth to where it gets to a severe case is usually between 10 and 15 years. So you have a patient that probably, if you caught the prostate cancer on day one of it developing, of course, like you get it out and you get rid of it. But if you didn't catch it at day one, or they just did not seek treatment, you start to see severe symptoms that are going to be life-threatening between 10 and 15 years. And that's why the screening recommendation is 50 to precede any issue that a patient will possibly have and register. So you hope that 65-year-old man that would be diagnosed with prostate cancer on average, you'd hope that if you could catch it at 50, it's so small, it's microscopic, and they essentially nothing really happens because you caught it so early. But if you don't catch it early and you do get your first screening at 65, that's typically on average when you're at the most severe place to where you're really going to be in danger.
Yes, sir. Dr. Hunter, we have one more question from Houston Texans.
Sure.
Going back to the symptoms,
Mm-hmm.
if you're having the weak or hesitant interruption in your urine stream,
Mm-hmm.
and then they start complaining of discomfort or pain when burning, the first thing they say, it's just my kidneys. I'm having a kidney problem, or
Mm-hmm.
I have a urinary infection. But as this gets worse and it starts to block the stream, is it palpable? Do you have something you can feel back there?
So if you do a digital rectal exam, then yes, if it's interrupting the flow of urine to the point where it's causing pain, and all of this is being caused by prostate cancer or BPH, because BPH and prostate cancer both cause like these symptoms that you're describing, then yes, you'll be able to tell that the prostate is definitely enlarged. But it would be via a digital rectal exam, as opposed to like, you wouldn't be able to tell unless you did a digital rectal exam. So it had to be done by a healthcare professional. But you could certainly,
it's not something you feel.
No, it's not something you feel just because of the location of the prostate. When it gets big enough to where you can feel it yourself, it's like pretty large.
Okay. Yeah. Thank you.
But you're welcome.
All right, I think it's time to play bingo. So Dr. Hunter, don't go, because this bingo is very exciting and I want you to see it.
Sure.
So
Sounds fine to me.
If you are at the YMCA, you should receive paper to be able to play the bingo. So Ms. Bean, please tell me if y'all have what you need for bingo. If you are at home, there's a link in the chat box that says virtual bingo link. You can click on that. And once I get an okay from the Texans YMCA, I am going to start.
We're ready.
Oh, awesome. Okay. Let's go for it. I'm ready to start calling. Can y'all see my screen?
Yes.
Yes, we can.
Okay. Ooh, no. Sorry. Don't see my screen. Don't see my screen. Okay. Let us restart this game. All right. Now let's share my screen. Okay. Are y'all ready to play?
Yes.
Yes.
All right, let's go. First call, diet.
Just put an X if you have the word diet.
So put an X on the word diet if you have the word diet on your card. Diagnose. Diagnose. So we want prostate cancer diagnosed as early as possible because the earlier we catch it, the more treatable it is. Dr. Hunter, is there something called watchful waiting? Do they still do that with prostate cancer?
There is recommendations when patients are diagnosed at later stages in their life where we identify essentially their life expectancy and really go through the process of would it really be beneficial to put them through so much treatment? Because it's still that 10 to 15 year mark I was talking about. If you get diagnosed at age 80, you really want to go through all of that treatment, it's kind of like you have that conversation because it's not an easy treatment to go through radiation and surgery and all these things. So some patients, we might just say, you know what, if you don't want to go through the treatment, you have, we feel you have a 10 to 15 years before this really causes a problem. We could address it when it causes the problem.
Okay. DRE. DRE is the digital rectal exam, right? So that DRE, Dr. Hunter, that is the primary reason most people don't want to go check their prostate. Do they really need to do that, or is there something else that they can do to check?
Well, the thing about the DRE is that even if your PSA is elevated, which is just a lab test that we can obtain from the blood, unless you can do the DRE and find this palpable prostate where it's really firm and it's like enlarged, then you're not going to do biopsies without doing a DRE to like clinically palpate the prostate and identify the fact that it's enlarged. So that's the second to the last step before you do the biopsy to diagnose it. You need to do that to identify the fact that it actually is enlarged.
But you wouldn't do the digital rectal exam unless they've done the blood test first, or would you normally do the digital?
They're actually done hand in hand. So the recommendations to do them hand in hand, because you can have a patient that there's a possibility that maybe the PSA is not elevated like we would expect to be elevated for somebody with prostate cancer, but then you did a DRE and they do have an enlargement of the prostate, which then could prompt the biopsy.
Okay. All right, just checking to see. Okay. Biopsy. Okay, biopsy was our next word. So biopsy is where they go in and take a little piece and check whether it's cancerous, right?
That's right. They use a needle to go in and draw out some of the cells, and those cells are then analyzed by a pathologist for us to see if it has the consistent types of cells that you would expect for prostate cancer.
All right, I hope y'all are marking. Survivor. Survivor, like Mr. Crossland is a survivor. All right, and whoever says or types bingo first wins. Counseling. Counseling. Exercise. So with exercise, Dr. Hunter, exercise helps prevent prostate cancer?
Yeah, it's more of a roundabout way of like addressing obesity. So obesity has also been associated with solid tumor formation in general. So the exercise keeps the amounts of, feeding material down for the cancers in general. So it's got a component. It's not as strong with prostate cancer, and that's because actually prostate cancer is driven by testosterone, but a lot of cancers are driven by excess carbohydrates and sugars being available for the cancer to feed off of them. So it still can help. But yeah, prostate cancer is one of the unique cancers that is actually driven pretty much 100%.
Okay, we have a bingo.
Oh, we got a bingo.
Bingo, woo! All right, I think we have a present or a prize for the,
Call out what she bingoed? You want me to call out what she bingoed on?
oh yeah, let's verify, let's be sure. that it's-
Diet, DRE, survivor, and diagnose.
Yes, yes,
Okay, great.
that is a real
Okay.
bingo. Do we have
Okay,
just one prize or do we have more than
have
one?
a prize here. She will get a prize from here. Okay, you're gonna start the second game now, right?
I'm gonna keep going. Keep your card.
Oh, keep your card.
Yeah, keep your card. I'm gonna keep going. Wait.
Bingo.
We have another bingo.
Awesome.
Okay, so what she has is diet, weight, survivor, and counseling.
Awesome. Congratulations. We have our second winner.
Okay,
Do we have one more prize, Miss Bean?
yes, we have one more.
Okay. Should we keep this card?
Yes, keep the card.
Bladder.
Bingo, bingo, we have another bingo. Bladder. Okay, what we have is exercise, weight, bladder, and diet.
Wonderful. Congratulations to our bingo winners.
And I will be presenting each of them with a special gift.
Oh, perfect. Perfect. Thank you so much.
Thank you. Thank you, Dr. Hunter. They enjoyed everything. Thank you so much.
I appreciate it. Thank y'all for tuning in.
All right. I just wanted to end by saying a big thank you to Dr. Hunter for presenting with us today and by inviting all of you back for October, where we will be talking about breast cancer. There is a survey. Let's see if we can present. Did we put the link for the survey here? Let me pull it up. There is a survey, and the first 10 people to complete the survey receive a prize. So if you can be sure to complete that survey, let me share my screen one more time.
You just want to go across. Oh, yeah, she's one.
No, we don't. She's supposed to be bringing it back.
Oh, the bingo. Why can't I share my screen? All right, so if y'all can. Oh, hold on. Share screen. There it is. Okay. If y'all can complete this survey, the first 10 people will be eligible to receive a gift bag that complete the survey. So the survey will just give us some feedback on how we did today. And it will also ask you about topics that you might want us to talk about in the future. October, sorry, the slide says prostate cancer, but October is going to be breast cancer. So we'll talk to y'all again in October on breast cancer. We're gonna have a physician from Houston Methodist that will talk to us about prostate cancer in October. And if y'all can copy this link into the survey for our participants from home. And the last thing is, if you want to share today's conversation, you can find us on YouTube, you can find us on Facebook, you can find us on Instagram, Twitter, LinkedIn. Send us an email. We have a website. You can give us a call, and we can direct you to any of the information that we presented today. So I'm going to stop on this slide so that if you do have any questions or concerns, you know how to reach us. Dr. Hunter, we so appreciate your time and breaking that down for us and teaching us new things and giving us some pointers on how to approach prostate cancer prevention. Thank you so, so much.
My pleasure. Thank you.